express my gratitude to Dr. Gupta and AIIMS Bathinda for giving me this opportunity to share thoughts on making healthcare safe. This presentation has got 4 sections. I will go fast. How much unsafe is the healthcare system? I know I am speaking on the podium in the Institute of Medical Sciences, but we must be realistic to assess the safety aspect of our medical sciences. Why has the healthcare system become unsafe? What we can learn from other high-risk industries, and how to make healthcare system safe and reliable. How much unsafe is the healthcare system? 4 in 10 patients, 4 in 10 patients are harmed in primary and outpatient healthcare. 4 in 10, remember. Around 1 in every 10 patients are harmed in healthcare entire system. In low to middle income countries, 4 in 100 people die from such unsafe care. About 50% of this unsafe care is preventable. This much is the problem which we need to address. ये मूव नहीं कर रहा आगे, ये स्लाइड आगे मूव नहीं कर रही, एक्सक्यूज मी, ये स्लाइड मूव नहीं कर रही आगे. यस, okay. So that was a global WHO study. This is our own Nat Health India's study. If you see our comparative figures, where are we in the last column? I will not go into details. Our Indian study has found out the challenges for which this healthcare system has become unsafe. There are again findings of Indian patient safety studies. Common adverse events, diagnostic errors, medication errors, surgical errors, healthcare associated infections, sepsis, patient falls, venous thromboembolism, pressure ulcers, unsafe transfusion practices, patient misidentification, unsafe injection practices. This was the diagnosis, at least description part. How much unsafe? 4 in 10 in outdoor and 40% in the entire system. Why has health system become unsafe? We need to go into the root cause. Yesterday I discussed about William Osler. Inherently medical science is a science of uncertainty and an art of probability. Our entire treatment protocols are based on population studies, trial studies, which are based on a common group, but because of this individual uncertainty, there are systemic and structural reasons for making healthcare unsafe. Today, the healthcare system has become the art of managing complexity. If you see the International Classification of Diseases 10th edition, there are 10,000 diagnostic, 70,000 diagnostic codes, 4,000 medical surgical procedures, and 4,000 labs. You can imagine the complexity. And how have we responded to this complexity in medical science? By specialization and super specialization and super specialization. So how did this super specialization lead to? It lead to fragmentation of care. We need to appreciate this systemic reason why healthcare system has become unsafe, because of fragmentation of care. Every specialist and super specialist is busy taking care of the disease. So fundamental question is, then who is taking care of the patient who is having that disease? It is something to think through. I will try to cover this in next few slides. Particularly the preventable aspect of harm, because we can't do anything about the specialization. There are more than 72 specialists and super specialists. In an eye ophthalmology, you've got anterior chamber specialists and posterior chamber specialists who doesn't talk to each other or miscommunicate with each other. So I am not going into those systemic reasons. I am going into here onward the reason which an individual physician on his own can prevent the harm. The most important 50% medical harm happen because of diagnostic errors. Diagnostic errors. 40 to 80,000 deaths, 1 in 10 diagnoses are wrong. 1 in 3 people surveyed have experienced a diagnostic error. 1 in 20% will experience a diagnostic error every year. These are the global studies by WHO. Why diagnosis is hard? We need to understand the diagnostic error. Diagnosis is fundamentally hard. Why? Because of patient variables, the stage of disease when it is coming, how it manifests, how it is perceived, how it is described, and when help is sought. If the help is sought at the stage 4 of carcinoma advanced, you can't do anything at that stage. But I am not going into patient variables. I will cover these two variables, the physician variables and the system complexity. The physician variables, knowledge and experience, across patient data, test consultation, skill in clinical reasoning, last point, stress, distraction, mood, time to think. One of the most important reason for health system safety is the clinician or the physician burnout. I will cover in the last section because of too much dysfunctioning in the system, 10,000 diseases, 5,000 lab tests. System complexity, I covered this. Communication problem, production pressures, tight coupling, access to care and expertise. So we generally see here in this cognitive level, but actually it is the background of system, the blunt end of communication, coordination, training policies and procedure which are responsible for this sharp end of diagnostic errors. This is the entire chart of our healthcare system, in which inside a system a particular transaction leads to patient harms. In diagnostic errors, why do they happen? Because of our heuristics and cognitive biases in clinical reasoning, and I have given certain examples. The anchoring, if I see the first case today of a particular disease, all subsequent cases today, when they will barge into my OPD, I will get influenced by the first case which anchored my mind. I will not see the second case, although they may be from different families, different background, but our mind gets anchored by the first case which I saw today, and that finally leads to a bias in my diagnosis. Anchoring, affective bias, availability bias, context errors. I am not going into details. You can Google it, find it later on because I have got a time constraint. Search satisfying, premature closure. The first diagnosis, it jumps to my mind and I go into a surface, identify 3 evidences and just satisfy myself without thinking through that it is my cognitive biases because of that availability bias, anchoring, etc. There are 192 cognitive biases which leads to failure in decision making. I am not going into that class of cognitive biases. How do these come together in a particular case? Systems and organizational factors, technological factors, human factors, patient-related factors, external factors. These are common root causes of medical errors. First is communication breakdown between those 72 specialists, between handoff between 2 specialists, handoff between the medical and the nursing team and the allied healthcare professionals. Communication is the number one problem, lack of information, human error, patient-related, organizational knowledge, etc. What can we learn from similar such high-risk industries in world? Can you think of any higher risk than medical industry? It is civil aviation. Civil aviation is a ultra-safe high-risk industry. Last year, I was in the flight going through the last year aviation safety data at global level. Last year, there were around 4 million flights and there were only 1 accident. So on an average, in 1 accident in 4 million flights, can we find out the same thing in our practice? So how the aviation industry has become ultra safe, high risk industry because of standardization and protocols and checklists, crew resource management of teamwork, communication, decision making, simulation training. I have seen an aviation simulator. The pilots, the co-pilot, the flight engineer have got more than 100 varieties of scenarios which they will find during turbulence, the flock of geese hitting the jet craft, and then how will they handle it. So, before the actual real life harm, they have got their simulation training happened and they are prepared. Whether in our medical education institution, we prepared our outgoing student for all varieties of medical harms, I doubt, because our curriculum does not cover the problem of patient safety. I went through the new curriculum also, patient safety is not there. Lessons from aviation industry, reporting and learning from mistakes without blames. The most important reason, psychological reason a medical team is that we hide by ignoring it, because of our psychological profile of being a professional experts, all knowing. So, we try to hide it. In aviation industry, every team member, even the crew member inside the cabin is facilitated to give a feedback after the flight, whether there was any adverse event during the flight, proactive safety culture, data-driven decision making, regular audits and reviews, human factors engineering, emergency preparedness, leadership and accountability, redundancy in safety system. There are 2 pilots, 5 crew members in a flight. In our case, we got 1 patient, and I don't know who is out of 72 in charge of that particular patient. Everybody is focused on the disease, but not a single case manager for that particular case. So, that was lesson from aviation. Now, how do we make our healthcare system safe and reliable? If you don't carry any other slide in mind, think only this slide. Every system is perfectly designed to get the results it gets. If we are getting today 40% medical error in our incidences, our system today is designed to give that 40% result. So, we need to think at the system level. The system is fundamentally on the right hand side the orange of culture, on the left hand side the learning system, and the safety culture start with first principle which Hippocrates 1500 years back. First, do no harm. I was talking to a professor from Harvard Medical School when I was in Harvard, and asked them that what do you think modern medicine so far has succeeded out of these. At that time it was international classification disease 9, so there were around 13,000 diseases. In medical science, he said only 25%. A professor from Harvard Medical School gave this anecdotal experience that only 25% diseases of 30 are medically amenable. Balance 75%, nature heals, but somehow we try to intervene all 100%. So, this 75% leads to this because of this. First, do no harm. If our medical science has not identified anything for this, you simply let him have a natural healing process. You don't intervene in all 100% cases. So, how is patient safety? There is a wonderful WHO document, I am not going to repeat it. They have designed a framework of patient safety, different levels of patient safety from policy, committee, organizational, interpersonal and individual. This is the entire framework of WHO patient safety. Tools for ensuring patient safety in a hospital: electronic health records, clinical decision support systems, barcode medication administration, patient safety checklist, I will show in the last, rapid response system, tool for ensuring patient safety in a hospital, tips to improve your diagnostic errors. If nothing else, the second last, consult peer. Patient does it, second opinion, but we feel psychologically hesitant to consult my peer in the same team. Patient always does it. I have gone to AIIMS Bathinda, now they approach me, sir, I want to consult the AIIMS Delhi for the second opinion. Why don't we take second or third or fourth opinion? In that area of AIML, we can consult AIML decision support system as a second tool. In the basic reason, now I identify, we have forgot the basic principles of medical sciences, where William Osler in the first textbook in 1890 says, he wrote the first textbook of medicine, Listen to your patient. He is telling you the diagnosis. I have seen in outdoors, patient has not yet started opening his mouth and the doctor has already prescribing the diagnostic lab which he is supposed to do. So now our modern medicine, Dr. Arvind Lal of the famous Lal Path Lab is a good friend of mine. He gave me this interesting data of India. He says, sir, now today in India, diagnosis is 70% laboratory medicine. Only 30% in clinical medicine, what I learned in King George Medical College in 1980. So this means 70% laboratory medicine, and all of us know all our tests are not 100% sensitive, not 100% specific. So if the test is not 100% sensitive or 100% specific, if they are less than 100% sensitive and less than 100% specific, then biostatistician says the prior prevalence of disease in the cohort in which that test is administered influences the outcome of that particular test. This biostatistical lesson we have not taught in our medical school. Therefore, what I see in OPDs and ICUs and emergency rooms, start passing the new generation of doctors, start writing 10, 20, 30 tests which they have wrote from the standard operating protocol, etc., without going into a prior statistics in that particular case. Though 20 tests are not required. The test specificity and sensitivity will depend on your ability to have a provisional diagnosis in the history and clinical examination. So this is my very important wisdom which I want to say. Listen to your patient. He is telling you the diagnosis. And if you will not listen to your patient, you will do lots of blunders leading to that 40% patient harms. These are strategies to mitigate cognitive biases in our decision making. I will cover only the first one, checklist. These are substandard checklists, globally used. They are used in AIIMS Delhi also. I checked up from AIIMS Delhi. I don't know whether they are used here. This is surgical safety checklist. It is used here in AIIMS Bathinda. Before every operation, the nurse in charge in the OT verbally goes through this checklist with the doctor and other team before induction of anesthesia, before the skin inspection, and after this, the surgical safety, the medical emergency checklist, the invasive procedure safety checklist. These are the invasive procedure safety checklists. Last important point for this MAPICON conference to the physician who are attending from on-site, online. The biggest medical harm which I see in Indian medical setup is burnout of physician, clinician. Burnout is a crisis for doctors as well as your patients. Remember this. 1 in 4 doctors reported feeling depressed. You know, in America they have done a study. Among doctors, suicide rate is twice of the normal population. Among doctors. And among the doctors, can you guess which specialty has got 3 times the average suicidal rate? Psychiatry. That is the level of clinical distress which is happening in our system. There is a India side, is a quick study which I can Google and found that in India what is the current crisis. Therefore, again medical dictum which was given to us in, I think, Hutchinson or Davidson, physician, heal thyself. So we don't want to carry any other lesson from this. Kindly carry this lesson. Physician, heal thyself. This is the current, this week's Newsweek latest issue, which is highlighted this doctor burnout, and they have made it a title of this week's, this is a current Newsweek, is AI the cure for doctor burnout? Today afternoon there is a session by somebody here, so I am not going the use of AI, ML in increasing the patient safety. Finally, I want to give a positive message. Martin Seligman is father of positive psychology, which provides the tools, techniques, models, studies on flourishing and psychological well-being. He had come up with a model called PERMA. PERMA, P stand for positive emotion, E for engagement, R for relationships, M for, can read anybody? M? Meaning and accomplishment. So kindly Google this, Martic Seligman, Father of Positive Psychology, that will give you those psychological tools, techniques of this PERMA model to make yourself immune to this psychological burnout. Finally, I used this slide yesterday. I hope that this presentation make you aware of the patient harm which we do, and good physician treat the disease, great physician treat the patient who has the disease. Thank you.